Hello, and welcome to our Impact with Aegis series. We're very excited that some of our top leaders within Aegis are presenting our topic, Delivering Value in Post-Acute Care in an Ever-Changing Landscape. My name is Shyla, and I'll be your host for today. Before I turn it over to your presenters, I'd like to go over a few housekeeping items before we begin. First off, please note that all lines are on mute. If you have a question or a comment, please use the question feature on your taskbar to send those in. We will have a question and answer session after the presentation so we can hopefully get to all of your questions. Please make sure that you have your own unique identifying login so that we have record of your attendance. If you're sharing a screen with someone who did not register individually for this webinar, please note their name and their email in the questions feature so we can have record of their attendance as well. This webinar is offered at 1 CEU for all disciplines. If you look in your handout section, there's an ASHA participant form for the SLPs who are interested in obtaining continuing education credit, as well as the brochure and the handout for the presentation. As a reminder, in order for SLPs to receive credit, you must send that participant form back to me, shyla.hamrick@aegistherapies.com, within 1 week. Additionally, OT and OTAs are required to pass a post-test to receive credit. I will be sending an email with the link to that quiz tomorrow. You must pass the quiz within 1 week to receive credit. If you do not pass the first time, you will need to email me and I can get you a link for the second try. Please allow me 2 weeks to get the certificates out. Okay, and with that, I will now turn it over to our moderator and the CEO of Aegis Therapies, Martha Schramm.
Well, good afternoon, everyone. Thanks for joining us. This afternoon's webinar is going to be a little bit of a shift from some of the others in the series, and I'm really excited about the panel. And what the panel's going to be doing is discussing some of the dynamics presently in our industry, and importantly, what are the opportunities that are emerging from those, and what are the changes? We're all aware that there are changes all around us, and that's a constant. It's not going to change. But the focus this afternoon is going to be to understand those dynamics, the opportunities, and then how can we influence our own future, if you will, affect our own destiny? What can we do as an industry and very importantly, individually within our clinical practices? So with that, I'd like to introduce the panel to you. Don Biggs is an OT. He, for 18 years, has been academic contributor and guest speaker to Creighton University's doctorate OT program. He's also the Chief Operational Officer at Aegis. Mark Besch is a member of the APTA Post-Acute Care Work Group. He also chairs the Medical Services Committee of ADVION. And ADVION is a large organization that champions legislative and regulatory advocacy for services provided in long-term care and in actually all post-acute care settings. He is also the Senior Specialist of Government Affairs and Analytics for Aegis Therapies. Dawn Greaves, DPT, is board member and publication chair in the Home Health Academy of the APTA. She's also the leader of the Home Health Special Interest Group for NARA. And NARA is an education and advocacy group actually representing over 80,000 therapists, as well as rehab providers and rehab support organizations. I'm an advisory member to the International Council on Active Aging, past president and present board member at ADVION, and I chair an advisory council to the University of Colorado PT program. We have some objectives this afternoon. You can see them here, but we're going to dive right into the presentation so we give as much time as possible to our panelists. So I want to start with just a little setting the stage here of the overall objectives of healthcare delivery in our country today. In 2008, the triple aim of healthcare was developed, introduced, and adopted. Later in 2014, that evolved into the quadruple aim that you see here. And presently, evolution is continuing, and the addition of a fifth element, health literacy, is being added. But for today's discussion, we're going to focus on the quadruple aim. Really what this does is it outlines and truly defines what constitutes value of healthcare services delivered today and in the future in our country. It is informing and helping decision makers, be they legislators or regulators, consumers, payers, make decisions about healthcare. And of course, all of that definitely influences our practices. So the real question is, how do we translate these objectives of the quadruple aim to our industry and to our individual practices? The quadruple aim has 4 elements. The first is quality of care, and it specifically points to the person experience. Consumer expectations are changing. The second element is lower costs. It is a mandate to identify and execute on opportunities to improve efficiencies, reduce waste and redundancies, and very importantly, to optimize how we allocate resources, both skilled and other healthcare resources. The third element is improving outcomes. And this is a mandate for both quality, but also safety of services. It is certainly improving the individual patient outcomes, but strongly looks at improving the overall health of the population. And then finally, the fourth element is the clinician and clinical team experience. It is the access and the support of and the promise of evidence-based care. It is improving the work life of clinicians, improving their well-being, reducing burden, and optimizing engagement. So if we go from this broad mandate and objectives to really what are the factors that are swirling around us, we are in the middle, the clinicians in the middle, and the many factors that are influencing our practices are important to understand, because the better we understand those, the more successful we can be in adapting to them, innovating around them, and shaping the next phase of change. So we're going to get right into it and start talking about what's happening and why does it matter. So Don, I think we're going to go to you first. Right up there on the 12 o'clock position is the demographic mandate. So that's sort of the population health piece. And so can you give us some perspective starting there?
Yes, absolutely, Martha. Thank you. So let's talk a little bit about the senior population and where it's going. As you can see on this graph, there's really 3 blue bars. And at the bottom of each, you can kind of see some different year segments. The first bar to the left is 2022. The middle bar is 2030, and the last bar to the right is 2050. If you look at the very top of each of those, it gives you the population 65 years of age and older in each of those different segments. So for instance, in 2022, there was an estimated 58 million people 65 years of age and older. In 2030, there were 71 million. In 2030, there's an estimated 71 million, and in 2050, 82 million. So you can see over 28 years, there's a 24 million increase in population in this 65 and years and older population. But what I think is even more interesting is look at the 80 plus range. You know, in 2022, there were 13 million, but it's estimated in 2030 to move to 19 million, and then in 2050 to 30 million people. That's a lot of people. And it puts a real perspective on the growth that we're seeing in our senior population. Let's talk a little bit about now those individuals and the chronic disease burden. On this graph, look at the blue section first, and it lists the different age groups, 18 to 44, 45 to 64, and then the 65 plus. So I'm going to spend my time talking about the 65 plus on this slide. So you can see at 65 plus, 64% of those individuals have 2 or more chronic conditions today. And even more importantly, you look at the geographic regions, and we know that as people age and they retire, there's a lot of studies showing, and we're seeing it all ourselves, that they're starting to retire in those more rural settings. And when you look at that, I think it's pretty astounding. In the rural segment today, 64% of those in that rural segment have 2 or more chronic conditions, whereas in the urban setting, it's 7%. So it's really starting to demonstrate to us, where the needs are going to be as the population grows, and it's really in our rural settings.
Well, so we've got lots more people that are in need of our service, and the access to those people may be a bit tough with that statistic of the rural population. Mark, so it's probably a good time to get to that second influencer, which is reimbursement. So what's on the horizon there?
Yeah, not such a good story. Before I go through this slide, it's important to define what do we mean by reimbursement, because I'm sure, as you all know, reimbursement for therapy service methodology is not the same in every setting. So if you think about all the settings where typically we have therapists, SNFs, hospital, home health, hospice, outpatient clinics, in some of those settings, it might be sort of an episodic or a bundled payment with like a SNF Part A stay or a home health episode of care. But more commonly, it's a per unit of service. And that would be, the example there would be Medicare Part B. So that's what I'm going to speak about today as we look at the history of reimbursement. Medicare Part B, because it's widely applicable, all 3 disciplines, multiple settings. So if we look back 10 years, what we see is a greater than 10% reduction in reimbursement over those 10 years based on the physician fee schedule conversion factor alone. And that's just one component that is impacting reimbursement. So what else is there? So that's 10% based on the fee schedule. What about the other factors? There's something called Medicare sequestration. That's been around since 2011, except for a couple of pandemic years where it was placed on hold. But that's a 2% right off the top Medicare reduction across all Medicare programs, payments, settings, etc. So there goes another 2%. Then there's something called the multiple procedure payment reduction. We might hear that referred to as MPPR. Started in 2013, and CMS said basically anytime a single patient receives multiple codes of service on any given day, even across our therapy disciplines, there's only one code that's paid the full fee schedule amount. And the other codes are all reduced by a certain value. And so that's another, depending on the number of codes that are billed, that could be somewhere between 6 and 10% additional reduction on those codes. That's on a daily basis. More recently, we've seen the implementation of the congressional mandated reduction in reimbursement for services delivered by therapy assistants. Medicare now pays 85% of the fee schedule rate for services delivered by assistants since January of 2022. So all of these factors, don't apply all of the time, but when they do, they can add up to reduced reimbursement in excess of 30% or more compared to 10 years ago. I think it's important to note also here that managed care plans will also have their own fee schedules and follow similar reimbursement patterns as they renegotiate contracts. I'm sure many of you are experiencing that. They get skimpier and skimpier with what they're willing to pay. All 3 of the professional associations have information like this available. I would encourage you, those of you that are members, to get on those sites. We're showing you an example of a piece that AOTA put together in 2023. And you will see some of those factors that I highlighted. In the top left, it describes MPPR. In the middle of the page, it talks about an 8% reduction. CPT codes over those years. And then in 2022, where it's highlighted there, that's the 15% cut for service to assistance. So as Don talked about, with changes to the patient profiles and the individuals we're going to be serving, an increased demand. This, in the face of these reimbursement challenges, makes for some interesting challenges moving forward.
Well, thanks, Mark. And, I'm bouncing the ball back to you, Don, here for a minute, because Mark just referenced some interesting challenges. And last I noticed, we've got more demand than we have supply of therapists. And so just cover off on that a little bit here to kind of put that third leg on the stool.
Yeah, so as we all know, there's lots of challenges here as well. So we're going to talk about us for a minute, clinicians out in the workforce today. So what are some of those factors that are driving some of the wages and staff shortages that we're seeing? Our healthcare workers are aging. We just got done talking about the people we serve, but the people that are serving those people are also aging. And, there are a high percentage of our workforce today that are beginning to get into retirement age and are planning on making the change and leaving the workforce. And what that means to all of us is that we're going to see a significant loss of experience and expertise in the incoming years. And then the reduced availability of workers. When you start to look at some of the statistics out there, a third of our nurses today across the industry are 50 years of age or older. And half of our physicians across the country are 55 years of age or older. So you're starting to see a lot of aging of our workforce, which does play an impact. Then we talk about keeping pace in our environment with our workforce. And let's talk about the educational systems. The educational systems have been through a lot of change in the last several years. As you all know, that, many of the programs out there across the board in PTOT and speech have moved from a master's level program to a doctorate level program, which, causes increased costs for our students that are going into the profession. And then they have to consider the debt associated with that as well. And so that is causing some limitations around people that are interested in joining the field. So that is a factor. Then you start to look at the admission rates of some of our programs across the country, especially in the assistant programs today. Several of the assistant programs are starting to see a reduced amount of admissions. Some are closing today. And when you look at some of the statistics around our professors in our schools, our professional programs, many of them are beginning to retire. And so they're needing to replace those individuals. And that is not always easy. So it's limited access to, supporting the amount of students that want to join our profession today. So you're starting to see smaller class sizes, which doesn't help where we're going into the future. And when you look at, for instance, AOCA put a report out last year, and in their report, they really showed, the number of clinicians that are going out into the workforce from an OT standpoint. And quite frankly, it's only increased 10% over 6 years. So that's not keeping pace with what I shared with you earlier around the growth that we're going to experience in our seniors as we move forward. Then you look at the uneven distribution of the workforce across our geographical regions. The same thing stands true. We talked about the population and the retirement age of people wanting to live in the rural settings across the country. Well, that is where we have the most shortages today of therapists and medical staff. And there's many studies out there saying that, there's 60 million Americans living in rural areas that will have limited access to primary care and, consumer-based services and community services in those communities, really causing a disadvantage for those individuals. And then we couple that with those individuals are having 2 or more chronic conditions. As they get older, it could be 4 more or even more than that. And who's going to serve those individuals? And so that is definitely a concern as we move forward. And then you couple all those 3 things together, and you talk about the shortages in our workforce today, right? We're not keeping pace from an academic standpoint. We're having people retire. We're having a lot more people not in the rural settings or limited. And, you know, it's causing stress for many of the medical staff across the country because of the increased workloads, and it's increasing burnout and dissatisfaction, and it's impacting the quality of care that we're seeing. Medscope put out a survey recently of physicians across the country, and it was interesting to find out that 40% of the doctors responded to say, of the doctors responded, 40% said that they're burned out, and that, you know, it's too much for them as well. So we definitely have some challenges that we're facing around our workforce today.
You know, Dawn, I think I'd like to tap you here, but Dawn, finish up on the job growth here. Help us understand.
Yeah. So what's exciting, I mean, for all of those kids out there that are excited about joining our profession, there's a lot of opportunity for jobs out there. As you can see across the board in our professions today, the employment growth is substantial. It's not keeping pace with what we need, but there's a lot of opportunity for people that are interested in this profession and this industry to join and have positions available. What I think I find real interesting and relieving to a degree, but needs to expand significantly, is a lot of the academic institutions across the country are now, about 25% actually, are expanding the distant learning programs. And so they're allowing access to people that perhaps can't move to a city where their program is located. Maybe it's a physical therapy or speech therapy program, and set up shop to go to school. Because they need to work, you know, they need to pay off their bills. And so they have the opportunity to seek those degrees via the internet. And it allows them the opportunity to be able to do that through a distant learning program. And that's going to help our cause as we move forward. There is a lot of projections out there to say that we're going to move from 25% to 40% in the next 5 to 6 years, which will help our industry considerably.
Thanks, Don. And so, Dawn, you know, I'm sure everybody on the call, you know, managed care is an increasing reality, and it's an important factor as we begin to move to talking about the opportunities presented by all these factors that we're discussing right now. But give us some thoughts on managed care and the value-based purchasing environment.
Sure, thanks, Martha. And so just to kind of start from a value perspective, right, you know, the managed care, the focus is that value services. Can you guys hear me okay? I'm getting an echo.
You're breaking up a little.
All right, let me know if it doesn't improve. So currently, there's 32.8 million people enrolled in Medicare Advantage plans. At 2024, that's 54% of Medicare eligible individuals. By 2034, that number goes to 64%. And you might ask yourself, why are people signing up for these plans? What's driving that happening? Medicare Advantage plans can offer things that traditional Medicare doesn't. That's the Medicare C part. They have to offer Medicare A, B, and D, but the Medicare C part is part of their model of care that they submit to CMS every year. And as a part of that, they can pay for services like podiatry or vision or some durable medical equipment that traditional Medicare does not. So that's attractive for people. Another attractive component is many of these plans are zero fees to the individual to join the Medicare Advantage plan. And so if you look at cost as a consideration, that becomes an important component of that as well. So moving on just a little bit to consider trends in care settings as well, because this is part of that picture of the healthcare overall. In 2023, 1.2 million residents resided in skilled nursing facilities. But the number of skilled nursing facilities is actually gone down. So in 2015, 1.367 million residents in certified nursing facilities, and in 2023, 1,204,000, so 1.2 million, that number that I just stated, are in skilled nursing facilities. And when you look from the data from the King Family Foundation and looking at, I'm sorry, Kaiser Family Foundation, goodness, from July of 2023, that data shows that nursing home occupancy was at 75%. In 2015, nursing home occupancy was at 82%. So we haven't fully recovered from the decline that we saw, as you can see on the slide here, with occupants in 2021 and 2022, though it has rebounded a little bit. But if occupancy is 75%, you can expect continued changes in that environment, right? That we'll see continued changes. You couple that with value, as we talked about, with folks wanting to be seen in their home. They're more, they express more directly, I think, to their physicians the care that they wish to receive, but also it is less expensive for that care to be delivered in their home. So that's when you start to get into that value piece of it. Just to give a little kind of a subset of value-based care models, a special needs plan is a Medicare Advantage plan. It's a category of Medicare Advantage plans from CMS. And there are three types of special needs plans. There's a CSNP, chronic disease management plan. There is the I-SNP, which we're going to talk about, institutional, and there's a D-SNP, which is dual eligible. Institutional special needs plan, it's just one type of a SNP, but it requires that the individual has been or is expected to be in a facility for longer than 90 days. They have to comply with all CMS Medicare Advantage rules. They have to submit a model of care like we talked about. The I-SNPs led by long-term care providers grew by 28% for plan year 2021. So the I-SNP plans can be partially or entirely provider owned. And so there are consortiums of skilled facility operators who have gotten together to support an I-SNP plan in their state, for example. So 115,000 I-SNP enrollees as of 2024. That's grown some since the last data from 2022, I believe, on this site. Not as fast as some of the other SNPs, but when you think about it, dual eligibles can be anywhere. They can be out in the community. This institutional is a subset of those 1.2 million that we talked about being in skilled nursing facilities. That's roughly 9%. Of that population. The interesting thing about value from this perspective is an I-SNP is an opportunity for skilled nursing facilities and therefore some of its partners going forward to benefit from enhanced quality. So delivering care that keeps the person in skilled facility and out of the hospital, which is the largest cost driver, as we all know, in the Medicare system. So keeping that resident aging in place, not bouncing back and forth to the hospital, is a benefit to the resident and family member because of the disruptions of going to the hospital. It is a benefit to the managed care plan and Medicare overall because of decreasing cost. But it also can be an advantage to the provider who can share in some upside of that savings from the quality that they're delivering. So these are the types of models that we want to be aware of and how we as a profession can impact and support these models and share in that quality and that upside.
You know, that I think that's a great segue to the opportunities. So the picture's been painted here, and I think everybody's pointed out there are challenges, but there are unique opportunities that emerge. And I think how we'd like to spend the rest of the time is I'd like to hear your comments on what those opportunities are. And I want to close with, so what's an individual able to do now, tomorrow, to move in that positive direction and capitalize on those opportunities? So I think, Dawn, let's let you go ahead and start. You talked about these different models. Give us your thoughts for what's out there for us to take advantage of at this point.
Absolutely. So, I mean, given the data that Don presented, the demographics of both our beneficiaries and the clinicians, and the disparity that we see there as that senior tsunami kind of comes forward, as well as the fact that more of our seniors are in a rural environment. For the general population, 15% live rural. For the senior population, 22% live rural. And so you combine higher acuity with a more challenging environment to bring caregivers into and declining caregivers. We've got to think about how we do things differently to meet this need. So telehealth is an example, and we learned to leverage telehealth during the pandemic, right? Because we finally had permission to do it. But what we found in using telehealth is that our outcomes are equal to or better than what we see with just traditional face-to-face. But that's a paradigm shift for us, right? We're used to being hands-on, right there with the individual. So there's been some resistance to telehealth, both on the part of facilities where we might want to offer that, and the part of providers, clinicians in using those services. But we've got to figure that piece out. The care extenders, use of care extenders. Top of license is kind of a phrase that gets thrown around quite a bit, but I need to be able to do as a PT only those skills that only I can deliver. So I need to understand what my PTA is able to deliver, and my PTA needs to understand what's non-skilled and what restorative or a wellness tech or a rehab tech at a facility could be delivering to put that care together. So how do we increase our touch points that we're having with someone while delivering more efficient and effective care, which improves the capacity of clinicians available while supporting strong outcomes, which is, of course, crucial to what we're doing. Last one is, oh, sorry, Martha.
Go ahead, Dawn, please.
I wanted to comment just briefly on modes of treatment, group treatment, concurrent treatment. There's good evidence that group is an effective mode of treatment and that it adds additional benefit for the residents who participate. As I've gone across the country doing site visits, the other thing that group does that is you can witness when you're witnessing a group is it engages the residents. And not only does it engage the residents, but for those teams who put it as a part of an individualized care plan and put those groups together in context of the individuals that they have on caseload. It can be inspiring for the clinicians and engaging for the clinicians too. So I think how we deliver care in different modes going forward is going to be important to be able to stretch that capacity, quite frankly.
Thank you. Great points. And Don, let's think about that fourth element of the quadruple aim, and that's the clinician experience. So how are clinicians going to be supported as we think about some of these opportunities?
Yeah, things are changing, and we need to be open to those changes. And Don mentioned think differently, and it's really my mantra moving forward as well. And in traditional settings, we want people to work 8 to 5. We want to work maybe random weekends, etc. And that's what we stick to. And I think we need to think differently about it. We need to be more flexible around how we support our clinicians to be able to work the hours they want to work and be able to balance work life. And that's important to people. And so, being more flexible around scheduling is key. And using some of those modes of treatment that Don talked about gives us the capacity to be able to support those efforts. The other thing that really I think is a great idea is that whole hybrid model. So thinking about maybe someone is interested in, maybe they have a job or maybe they have childcare issues to where they need to watch their child or be home for half a day. So could we have them doing telehealth for half the day? And then maybe they still want to be able to get into facilities and do hands-on care, and they do that the other half of the day. And so being really creative around how we look at, looking at a clinic-based model to more of a telemedicine model as we move forward, or a hybrid model. And then I know we've had some experiences where we've had two moms that want to stay engaged in their profession, but, they want to stay home with the kiddos and they want to support them as well. And so how do they do both? And so we've had moms come together, perhaps two PTs, and say, look, I can work, a couple hours, 3 to 4 hours a day. Can you work 3 to 4 hours a day? Perfect. So we put those two people together, and we get a full week of service from two PTs that are, really engaged, because they're getting to balance work and life as well. And so, just really thinking, I think, very creatively about it. And then the rehab tech piece, as Dawn said, we're seeing a lot more students. I talked about students earlier. Students really want to, and they have to, get so many volunteer hours before they can get accepted into academic institutions today. We can leverage that by having them come into our clinics and learning to be around and experience our practice by being a rehab tech. They're motivated, they want to learn, they want to engage in the patients. They're the perfect person to have in that role and to help support us, as Dawn said, as we really help our clinicians, all of us, work at the top of our license and making sure every minute counts when we're in those facilities today. So those are some of the ideas, Martha, that we've been able to experience recently.
Well, as you said, we have some paradigm shifting in front of us, I guess, and moving away from some of the traditional paradigms. And so, Mark, log in here. What are the opportunities you were describing? Not a very encouraging reimbursement environment. What are the opportunities that are out there for us, though, to influence that?
Yeah, I think what's important to think about is, I want to talk a little bit about value. Just think about the title of today's webinar, right? Delivering value in post-acute care. So think about what that means, and value to who? Is it to the patient? Then that could mean, optimizing function. That's what delivers and creates value to the patient. Is it value for the setting, the institution, the facility? And that may mean being efficient. So maybe they measure it with length of stay or some other measures, but being efficient. We want you to do what is necessary and what works best. Or maybe it's the payer, and they might measure it by length of stay. But we also know that payers are expanding their definition or measures of value. Think about the Medicare program and the value-based purchasing models that apply to every single setting that we've addressed today. And what are those measures? What are those metrics? It might be the discharge rate to the community. It might be the Medicare spending. How much does it cost the Medicare program? That's a measure of efficiency and value. It could be feedback from surveys. Home health industry uses patient surveys. The hospitals use patient surveys. So all of those things speak to value. So as understanding the measures of value is critical when we start trying to impact value. So when we talk about what we can do, what can we do, what can you do to impact value? Go back to that statement I made a minute ago. Do what is necessary and do what works best. Do you know that? Are you measuring outcomes? And that's kind of a broad word, but just think about that in terms of what data do you have available that could help to demonstrate your impact? Are you collecting that data? Think about those value-based purchasing program metrics: change in mobility, change in self-care, discharge to community, rehospitalization rates. Think about what data points might be available to you. You may not have feel like you have a outcomes collection system But chances are you have data. What would those data points be? Minutes, visits, length of stay, change in function, like we referred to. Are you utilizing tests and measures? That's something that you can do because that creates data points to measure effectiveness, to measure change. Remember, one of the tenets of quadruple aims, improved outcomes. Well, you have to have data to be able to talk about outcomes. So have you identified data points? You can identify data points to measure your impact. So for example, whatever your measure of therapy intensity is, do you understand what intensity levels produce are most effective? What produces the best impact for your patients? And it's likely that not every patient is the same. So how do you begin to study that and understand that more? You can use that data for continuous quality improvement. Be efficient and effective through data. Another tenet of the triple aim, right? Lower costs, efficiency. One thing we haven't talked about is technology. How can you use maybe technology to help? Are there new technologies available? Think about remote monitoring, for example. Even outside of the billing codes and so forth available for remote therapeutic monitoring, but imagine if you had a way to connect with your patient remotely to be able to get feedback from them on their home exercise program. How are they doing? How are they performing? That allows you to intervene when necessary, but do so very efficiently, maybe even without having to schedule return visits. You could do that remotely. And there's some very inexpensive remote monitoring apps that are available. Are there other efficiencies that could be explored? AI, artificial intelligence. I like to refer to it as augmented intelligence. It sounds a little friendlier to me. But is there AI opportunities you could use, maybe to reduce administrative burden, admission process, for example, or maybe even documentation? So you can explore AI opportunities as well. And Martha talked about what can you do? How can you get involved? It's really be active, understand the opportunities that you have to advocate for what you do and where you do it and the people that you intervene. We've got some important legislative activities that will need to occur between now and the end of the year. Congress is wrestling with reauthorizing a lot of the government spending, but we need our telehealth flexibilities that we've referred to several times here during the call to be extended, because right now they're due to expire at the end of this year. Interesting, the House Energy and Commerce Committee was holding a hearing today, and one of the bills they were considering is called the Telehealth Modernization Act, and they want to move that out of committee into the full House for more debate. It's not a very efficient process. Speaking about efficiency, they started at 9 o'clock this morning, and as of when I needed to get off to join this webinar, they still hadn't taken up that bill, and they have about 10 additional bills they wanted to do. But I expect that they were going to vote that bill out of committee because it needs to get to the House floor. When it does, that's the time that you can get involved. So your company may have opportunities for you to message your congressman or your elected officials, or again, the professional associations have that activity, that opportunity for you to do that. So that's something that you absolutely can, and I would say should do for the benefit of all of the professionals.
Well, yeah, I think it's important to be, I'm sorry, Mark, just follow up on Mark's comment. I think it's important to be a member of your professional association, right? I do support that, but this is one thing that APTA, AOTA, ASHA allows you to do as a non-member is access their site, right, to send a message to your representative. So it's super easy to do when those bills come across to be an advocate, to use your voice.
Thank you. It's a great example of what difference one person can make. Don, what's the power of one from your perspective?
I'll just add a couple things. And Mark talked about AI. I'm pretty excited about that. And I'll just pick on a couple things. One is the predictive analytics piece. All of us that work in long-term care, we have to go out and do screenings, and we spend a lot of time doing screenings, and sometimes it takes an hour each week to do screenings. And sometimes you come back and you've had a successful day of identifying people with change of condition. Sometimes you don't, but it takes time. And when we talk about time and efficiency, embracing AI is really important. And a lot of our long-term care customers today are embracing predictive analytics out there. There's companies out there today that are connecting with our customers' EMR systems, and they're evaluating the documentation that's being entered every day. And from that, this system can give you on a weekly or even daily basis, at-risk residents. So it kind of eliminates the need to be running around screening patients, right? It allows you the opportunity to go to one place, look at those individuals that have potential for decline, and go and pinpoint those individuals. So you're not spending so much time on the floor looking. You have a path, you have a focus of individuals that you need to look at each day relative to what that AI is telling you, which is pretty powerful. There's some really good monitoring systems that are going into some of our customers' facilities to really, as Mark said, monitor what they're doing when no one's in those rooms, and being, open to understanding how that technology works and how it can benefit you in terms of seeing change of condition in our residents, so we can be, more on the spot with those changes. And we know from research, the quicker we can get in there, the faster we can, take care of that issue without it becoming a significant issue. So I think that's a big one as well. I think the patient portal, Mark kind of talked about that too. Really, there's a lot of advancements around that. And I think not only is it a great communication device, but it's a way for us to connect with families and help with carryover of services, and encouraging our families, because families are more involved today than they ever have been in the care of their loved ones. And if we can empower them to carry over some of the things we're working on in the clinic, to get that person better sooner and faster, and maybe follow through with some of the things you're asking them to do, and to have more compliance there, it allows you to have more efficient practice. And then I'll say one more thing, Martha, and that is the academic institutions. I'm a huge believer in the fact that most of our academic institutions today don't know what we're doing in our space today. They don't really truly educate those students around what goes on in our facilities, what opportunities there are, and quite frankly, the excitement that can be held with the services we provide and the outcomes we obtain. And really, for all of us, one thing you can do is connect back to the schools that you're in, and get an opportunity to get in front of those students and share the good news that's going on and what we do in our profession. Because sometimes in the absence of communication and education around that, we get a negative stigma out there, and therefore those people don't come and join us in the field, and we need them to do that. So there'd be a couple things that I would suggest, Martha.
Thank you. We can all point back to our alma mater and engage a little bit more. It's a good,
That's right.
good challenge. Dawn, you were talking about changing the model of care. And again, I'm going to point to the fourth element of the quadruple aim and the clinician. And big part of that is evidence-based practice and supporting that. I suspect you have some good thoughts on that.
Yeah, I think when you think about, when I go to a webinar or training, I feel like I've benefited if I leave there kind of with one tip or trick to take away, right? To be able to next day kind of hit the ground running or apply. And something that is within the purview for all of us to do is appropriate dosing. Evidence shows us that we underdose our seniors, and particularly those with frailty, with a diagnosis of frailty. But evidence also shows that we need to work them harder than we're working them, right? They benefit from the same strength training principles that we use if we were to go to the gym. What's the 1 rep max, and what intensity are we delivering that care at? Don mentioned, I think, minutes matter, making the minutes matter. So when I'm with that individual, am I truly taxing them beyond what someone who is non-skilled could do in, of course, a safe way, because I'm a clinician and I know how to do that. Or am I in a rut with 2-pound weights or a weighted wand, or right, those kind of traditional approaches. We need to link functional activity for the resident and their family, or the patient and their family, the individual and their family, to the functional gains that they're looking to make. What does this mean to my life? And it's kind of hard to do that to a 2-pound ankle weight. But if you're doing weighted sit to stands, right, and practicing sit to stand with different heights, so that you're truly optimizing the activity that individual has to perform, it's pretty darn easy to equate that to, this is to help you get out of your chair better because you want to go to your grandson's wedding, whatever that might be, right? So that is definitely, we're in control of that as professionals, understanding the evidence and applying the evidence, but just that one thing, thinking about your dosing and is it appropriate, is it enough, would be a good place to start.
And I know you've been leading that charge in lots of ways, Dawn. Are there any outcomes? I mean, you talked a lot about the managed care and the ISNP, and we have to, Mark, you talked about we have to do just enough. I mean, we need to know what actually tips the scale for difference, and when we're at a point where maybe the improvements and the outcomes aren't going to significantly change that patient's functional status. So, Dawn, do you have any input for the listeners in terms of your experience with clinicians with regards to this dosing concept and really getting much more intentional around that?
Yeah, and as you know, Martha, we partner with University of Colorado, which is CU, which is backwards in my brain, but in a research study that they're working on for high intensity dosing of seniors. And as we've done that at the sites, it is energizing to see how the therapists go from, that's going to be too much, to this is so effective, right? We're seeing so much difference with this. And that's anecdotal, clinician by clinician, but you feel good at the end of the day if you really feel like you've made and can see progress with an individual. So I think that's part of it. I think from the treatment modes perspective, we've been looking at our outcomes for telehealth. We've been looking at our outcomes for group. And as we do that, we're seeing that the outcomes are equal or better. And so as a clinician, I want to know that what I'm doing is effective, and I'm not going to necessarily believe you. You have to show me, right? And so we are starting to gather that data and information to be able to share with the clinicians, so that we can all think differently as we embrace how we address the future. I'm not sure if that addressed your question, but.
No, I think that's helpful, and it's probably a good time to pause and see, Shyla, are there any questions in the chat?
There are.
Let's try to knock a couple of those off here in our remaining time. You want to go ahead and give us one?
Are S&P plans reimbursed with fewer reductions?
Mark, do you want to
reimbursed with fewer reductions?
Or Dawn, go ahead.
I think, yeah, talking about special needs plans. They function differently, but special needs plans are often a capitated reimbursement, and so the facility gets in example of an ISNP. Sometimes it's a capitated reimbursement, sometimes it's a fee-for-service reimbursement. It really varies by plan. And I've said to our team, if you've seen one ISNP plan, you've seen one ISNP plan. They do vary widely, but typically it's a capitated payment with that upside opportunity for quality. And so what it does a little bit is takes the gloves off, right? It's no longer a fee for service. I am going to get X dollars to care for this individual in my facility for this period of time, and I can deliver that care however I see the care being delivered best. I think we've all had moments when of frustration when, you know, you get somebody better and then they go on restorative and then they decline and then they circle back to therapy because they didn't get consistent restorative or a consistent care extender. Being able to allocate those dollars a little bit differently and how we support those individuals is actually quite freeing in thinking about how we deliver care. To Don's point, intervening sooner with those risk tools so that when we are looking at that individual, we're not immediately thinking therapy 5 times a week, PTOT, what can I do, right? We're thinking as an interdisciplinary team, we've caught this early. What do we really need to do for Mabel to get her the best outcome? And it might be 2 disciplines 5 times a week, but it might look very different. Using a care extender while we're delivering services, right? We always think about discharging to a downstream care extender. Why not leverage those care extenders while we're delivering services to increase that value?
It increases our flexibility, I think is what you're saying, which is really a liberating kind of.
Yeah.
How about one more, Shyla?
Okay. Do ISNPs also offer reduced costs to the resident or family for long-term care costs? As we know how costly long-term care can be for families.
Yeah, it's a Medicare replacement managed care plan, right? So it does not pay the day rate. So that the day rate for room and board isn't a Medicare benefit, and that is not covered under those ISNP plans. They do cover some things, like some of them will cover a food allowance, some of them cover DME, dentistry, podiatry. Some offer a nurse practitioner that routinely sees the individual. So no, it's that care service model, but the day rate is still, if it's reimbursed by Medicaid, it's still paid by Medicaid. If it's privately paid by the family, unfortunately, it's still privately paid by the family. So those costs don't change.
Maybe we can squeak one more in, Shyla, if we have a quick answer.
I'm curious on what specific setting that telehealth is resulting in equal or better outcomes than face-to-face therapy, and who is conducting the movement and steadying of the patient during the telehealth examination/treatment.
Mark, you want to take that, or you want me to take it?
Yeah, no, I can take that certainly. The bulk of the telehealth data was generated from therapy services delivered to SNF residents, both short-term and long-term. In terms of the who's conducting the steadying of the patient, our practice, and I know based on discussions I've had with a number of other companies, is that we have 2 people involved in the visit. One is the remote person, the therapist, and the second one is usually a therapist assistant or a rehab tech. But a person who's trained enough that can do 2 things primarily. One is assist the patient with the technology if that is necessary. And then secondly, assist the therapist in terms of providing, maybe it's a cue, maybe it's that steadying influence for the patient. So an in-person individual along with the remote individual.
And with that, we are at the top of the hour. So Shyla, thank you for being the hostess. Thanks everybody for joining us. And we'll say goodbye and thanks again.
Thanks, everybody.
Bye-bye.
Bye-bye.